Hello? There we are. Now it's real loud. Hello, everyone. Thank you for coming to our session here this afternoon. My name is Cheryl Needham with Philips, and our session that we have here is called Cost Effectiveness of Home Non-Invasive Ventilation with Home Oxygen Therapy After an Acute Life-Threatening Exacerbation of COPD in the United States. Our speaker today is Dr. Gerard J. Criner from Temple University. And as you can see, he's also one of the investigators as part of this health economics that is an add-on from the hot HMV study that you may have heard last year here at ATS that was presented and in JAMA a year ago. So I'd like to introduce, again, Dr. Gerard Criner coming up here to speak to you this afternoon. Thank you.
Thanks, Cheryl. And thanks for the opportunity to speak about this. So all the people that are listed here as authors, I'm the least deserving overall, and that'll become pretty clear. The only thing I know about cost effectiveness in a hospital is my administrators say I spend too much money, and my wife does my checkbook, so I don't really know much about costs. But what I do know is how to not get a grant approved for a large-scale randomized controlled trial of efficacy for non-invasive ventilation. I've been an architect of about 6 proposals in the last decade. None of them have ever got funded, but we have a submission that's presently before the NIH that looks more promising than the rest have. And the reason why I got involved with this is with Nick and Patty, is that they did a trial in the UK. And this was an opportunity to see if their data showing a successful clinical outcome, how would that look in an economic model in the United States? Could we create a cost-effective scheme using non-invasive ventilation if we had results such as they found? So that's really what the background context of how this study came about and was designed. As most know in the room, the in-hospital burden of COPD in the United States is large. There's about 1.1 million COPD-related ER visits. There's 600,000 discharges from the hospital on an annual basis with a diagnosis of COPD. It's 20% of all 30-day all-cause readmissions, 20% across the United States. And you know that the high mortality that there is for patients who have hospitalization for COPD, 2.5% for exacerbation-related admissions, and up to 28% for patients who have respiratory failure that require ventilation. If you look at the right side graph overall, you can see that if you look over the last 4 or 5 years, that the admissions for congestive heart failure have gone down, acute MI have gone down, but the admission rate for patients with COPD has stayed relatively constant. So not so far a great outcome for us. And we do know the impact of those patients who have frequent exacerbations and who have severe exacerbations that require hospitalization. The more you have, the more deadly they are, such that people that have up to 3 hospitalizations over a 5-year period of time, in this study in Spain, showed approximately an 80% mortality. If you look at the driver of healthcare costs in COPD management, it's really the hospitalization event, which drives the cost extensively compared to the outpatient costs that patients have. Not to say that the outpatient costs aren't trivial, but it's the inpatient cost of care for patients that are hospitalized with COPD that are the greatest driver of cost. And if you look at COPD-related healthcare costs and how that's related to repeated admissions, you see this curvilinear relationship. Your first hospitalization, which is here, you can see the cost of $3,700. The second one doubles, and when you go up to 3, it quadruples over time. So there's an ascending increase in the cost of care for a sicker patient who's repeatedly hospitalized because of their COPD. So that's some of the contextual background why this is an important issue and why it needs to be studied. So I'll just refresh you for Patty Murphy and Nick Hart's work that was published in JAMA about last year this time. And this was a study that basically looked at the use of NIV as add-on therapy to standard care an oxygen therapy to see if it decreased the time to readmission with an all-cause endpoint of hospitalization or death in patients that received NIV compared to long-term oxygen therapy itself. Secondary endpoint was, did home NIV reduce exacerbation frequency and 20-day hospital readmission rates? And there's few studies that have examined the cost implications of this, so they added this arm to their study. There's a companion UK analysis, and then I tried to modify it with others to see how this would work in a US model. This is their study results overall in terms of clinical outcome. The patients that were treated with home oxygen and NIV had a higher emission-free survival than the patients that were treated with home oxygen therapy by itself. This difference was mainly driven by hospital readmissions as opposed to a reduction in mortality. So our objective, as I mentioned, was to evaluate the cost effectiveness of home NIV with oxygen for treatment of COPD with persistent hypercapnia, modeled on the UK study clinical outcomes in a financial model of the US with a US care pattern. So overall, the study design was a priori secondary analysis of randomized controlled trial data. We used a cost effectiveness model. This is run by Quinn and Tom Goss, Quinn Gao. The time horizon was at 12 months. Perspective from a US payer. The efficacy data analysis was based on an intention to treat approach. The resource used was measured in a randomized controlled trial. There were exacerbation events, related events such as hospitalization, outpatient visits, and self-treated exacerbations the medical therapy would usually use. Antibiotics, the cost of antibiotics in the United States, short-acting bronchodilators, long-acting bronchodilators, the cost of oxygen in the United States. And then we used patient reported medical resource was collected from the patient diaries that was done in the UK studies at 6 weeks, 3, 6, and 12 months after baseline to get a handle on how they were using their outpatient facilities and outpatient visits. And then the utility values were calculated using the European Quality of Life 5D at 6 weeks, 3, 6, and 12 months. The cost of medications associated with the management of acute exacerbations were included, and we looked at the two types of major devices that are used for non-invasive ventilation in the US. The bi-level devices that are used, the respiratory assist devices, as well as if a home mechanical ventilator had to be used because of whatever issue that the doctor was trying to treat or because of working with their insurance carrier to see what they could get for the patient to perform NIV. The monthly cost of home oxygen was considered to be equivalent between the groups, no difference between the ones that got oxygen plus NIV compared to oxygen alone. And the device costs were calculated monthly based on the actual period of the device use. So if the patient was intention to treat and they just used it for 6 months, we just used 6 months as opposed if they use it for 12 months for the analysis of the cost. And the costs were inflated to 2017 US dollars. The incremental cost effectiveness ratio, the ICER, was used, and that's the total cost of the intervention minus the total cost of control divided by the quality adjusted life years with the intervention minus the quality adjusted life years with the control as the ratio. So this was the clinical results, just to remind you what Patty and Nick found. There was 116 patients treated in a UK study overall, 57 to the intervention group, 59 to the control. In this base case analysis, 64 patients out of this group of 116 completed the 12-month study period. The median time to readmission or death was 4.3 months in the group that received NIV plus LTOT versus 1.4 months in the control group that received LTOT plus usual care. The 12-month risk of readmission or death was 63.4% in the NIV plus LTOT group versus 80.4% in the LTOT plus standard of care group, showing an absolute risk reduction of 17%. You can see the confidence intervals here. At 12 months, 16 patients had died in the intervention group versus 19 in the control, and this wasn't statistically significant. So this is diving into these elements of the care plan that may drive the cost. The intervention, the NIV group here is shown in the purple, and the control group is shown in the lavender, I guess it is. You can see here in the mean number of events shown on the y-axis, exacerbations needing admission were lower in the NIV and, group compared to the long-term oxygen treatment standard care group alone. Exacerbations needing a physician's treatment, patients in the intervention group had more physician contact overall, more exacerbations were self-treated, and exacerbations needing no treatment were less in the number of deaths as I mentioned before. So overall, less admissions to the hospital were indirectly correlated with the patients getting more physician treatment, getting more treatment by themselves, and having less exacerbations that needed less treatment. So these patients in that group that received NIV actually received more care for COPD-related events as an indirect correlate of their outcome. If we look at medication usage and outpatient visits, again divided between the groups, the mean number of days with increased steroid inhaler usage was greater in the control group. The mean number of days with increased use of rescue inhaler was greater in the control group. And the mean number of days on steroid tablets was the opposite, was greater on the intervention group, as was the mean number of days on antibiotics. So was there some differential in usage? People were treated more with antibiotics and steroids in the intervention group compared to control, but the rescue use of medication was greater in the patients that were on the standard of care arm overall. This is the kind of like the essence of the study for the cost effectiveness standpoint right here. This is divided into 3 segments. One is looking at the total device cost as shown at the top. The intervention group is shown in this column. The control group receiving standard of care here is shown in the right. And as you can see that the cost for the devices was higher in the NIV group because they were receiving one of the either respiratory assist devices or the home ventilator compared to the control group. The total exacerbation costs were slightly less in the intervention group compared to the control group, and total patient reported costs were also lower in the intervention group compared to control group. If one looks at the total costs overall, in a group that received NIV plus standard of care, the total cost of care on average per subject per patient was $24,458 compared to $28,000 or $4,000 more per patient compared to standard of care. The total quality of life adjusted years was higher in the NIV group. It was 0.4874 versus 0.410 in a group that received standard of care. So our ratio, as you can imagine, is going to be positive, favoring treatment with intervention with NIV because our total cost was less. See the cost reduction here, and our quality of life adjusted years was higher, so our ICER would favor the intervention group. So in summary, in the NIV intervention arm, the device costs were higher, the exacerbation costs were lower, the medication costs were lower, the total costs overall were lower, and the quality adjusted life years were higher. And this is pretty much breaking it out for you is the cost effectiveness results on the intention to treat analysis. Total cost, as I said, was about $4,000 different. Quality adjusted life years 0.07 less. And then the ICER showed adjusted cost for quality of life years was about $50,000 less. There was a one-way sensitivity analysis that was done. Don't ask me to explain this. This is done by Tom Goss. It was looking at if you took the minimum and the maximum cost effectiveness of each of these variables, trying to look at the boundaries of more cost versus less cost, shown here on each of these parameters: hospital admission cost, cost of death, titration cost, oxygen cost, cost of physician-treated exacerbations, cost of self-treated exacerbations, diagnostic test costs, the cost of untreated exacerbations. And even within these parameters of the max and the min, still was cost effectiveness that favored the group with NIV because you reduced the cost of the admission. So when you look at these plots overall, these cost effectiveness planes, if you look at the top part of this, this is the middle of the grid with 0 being the starting point. Above this are cost interventions that are more expensive. And to the right side of this are interventions that are more effective. So if it was up here, that would be an intervention that's more expensive but effective. If you look down at this bottom right plot where the NIV study from Nick and Patty's study was, this is where you'd like to be. This is an intervention that was not only effective, but was cost-effective overall. So our summary from this cost analysis, modeled after the UK study, was the cost of home non-invasive ventilation device-related costs was the major driver of the ICER costs. In the base case analysis, we used a bi-level device with a backup. That was where we had the minus $50,000 cost of intervention. When we changed that to using the home mechanical ventilation, the cost went up to $24,000 per subject, but it overall still was a favor of ICER. It just wasn't as favorable financially as it was with using the bi-level device overall. The incremental reduction in costs associated with less exacerbations, like I gave you in the preamble, that's the most expensive cost of care for COPD patients, had the greatest impact on reducing the overall cost of care. And then the major limitations is obvious. We didn't do the study in the United States. We extrapolated everything just to find out what would it look like in a US model. And there were certain assumptions that we made. Remember, if you're familiar with their study, and most European studies with non-invasive ventilation, they keep the patient in the hospital till they acclimate them into the hospital. Can't really do that in the United States. So what we did is set up outpatient sessions, and we modeled that. And if they needed a sleep study, it was an at-home sleep study, or it was an outpatient supervised sleep study. So our cost assumptions were altered based on trying to make it fit into the US model, plus all the other costs of medications, interventions, and respiratory therapists itself. So the titration in the outpatient setting could have we could have underestimated what the cost would be. And the final thing is that the cost of life values were calculated by using a US-specific index related to EQ5D, that we looked at the improvement in quality of life in a British patient population compared to the US population, and that could be vastly different, but they voted for Brexit and we exit and Brexit, and we voted for Trump, so maybe it's the same overall. So our conclusion overall is that NIV plus standard of care with persistent hypercapnia followed hospitalized exacerbation could potentially be cost-effective, more effective and less costly. Also, if it was used in a US healthcare system, the NIV is sensitive to device costs. So if this is going to be an effective modality in the United States and we want to maximize the cost effectiveness and patient benefit, then we're going to have to work on a model where the most effective and least expensive device is used. So that's it. Open for questions.